Hi, everyone. So we can get started because Dr. Kaltenbach has some pretty good slides for us for today. So thank you for joining our webinar series. Some housekeeping slides first, and then we can go on. So important things is we can if everyone can mute your microphone just to kind of give the speaker uninterrupted speech, and also to enable your video just for a more interactive session. And then how to ask questions. You can definitely ask questions as they come. Dr. Kaltenbach has several questions for us during her slides. And also you can also place in the chat function your questions we can ask Dr. Kaltenbach after her talk as well. So how to change your username. It'll be great if you can just change maybe your first and last name in your institution. And just for all of us to get to know one another. And then for Cme Accreditation, if you do want to obtain Cme Accreditation, you must register. A survey link will be sent to your email that you register with. If not, there is definitely you can go through this website or a QR code, which I'll leave for just a brief couple seconds for you to scan. And for our fellows, we are trying to, pre-COVID, we are trying to make this webinar as helpful as possible. If you did obtain a meal, please submit your receipts to Danny so that she can reimburse you. Here are our upcoming webinar series. The next one is going to be Dr. Gish on August 24th to save the date, and followed by Dr. Wachter from UC Davis. And our education committee, thank you for our chairs as well as our fellows for making all these process possible, and also for Danny for our help. You can follow us on Twitter, YouTube, as well as Facebook. And I have the privilege to introduce our speaker. So it's my great privilege to introduce our speaker this evening, who happens to also be one of my clinical mentors, Dr. Tonya Kaltenbach, Professor of Clinical Medicine at UCSF, as well as gastroenterologist and advanced endoscopist at SFVA, where she also serves as the Director for Advanced Endoscopy. She serves on the U.S. Multi-Society Task Force on Colorectal Cancer, the NCCN Network for Colorectal Cancer Screening Panel, as well as the ACG Educational Affairs Committee, and recently led the guidelines to developing endoscopic removal of colorectal lesions. Her clinical and research interests primarily focus on improving the quality of colon cancer screening through endoscopic imaging, advanced endoscopic therapies, novel training vectors, as well as developing evidence-based clinical guidelines. Lastly, her role in medical education and training of gastroenterology fellows cannot be emphasized enough. She serves on a PI as well as has several studies trying to improve endoscopy training education, and also has developed several simulation-based mastery learning curricula for basic as well as advanced endoscopic therapies, which has been adopted across several training institutions in the US as well as Asia. She is a recipient of numerous research awards, as well as the author of nearly 200 articles, and is known nationally as well as internationally for her work in studying epidemiology for non-polypoidal colorectal neoplasm, as well as the role of endoscopic resection of these complex polyps. Thank you, Dr. Kaltenbach, for taking the time to teach us about this very important topic.
Thank you, Neem, and thank you to the Northern California and the Southern California Societies for Clinical Gastroenterology. It's a great privilege to speak to all of you today, and it's very exciting to speak to you at this stages of your career. And I hope you continue to hold on the passion and the interest to learn throughout your gastroenterology training, as certainly the field continues to advance and the way we learn how not only the cognitive parts of the field, but then the technical parts, it continues to advance and we adapt with that. And with that, I was asked to speak about updates and controversies in colorectal cancer screening and surveillance. There have been recent updates in the last year, in fact, in both of these areas. And so we'll use this time together to discuss them. I would like us, next slide. I want us to take a moment to say, well, how are we going to spend our next hour together? And our objective is for us to review current colorectal cancer screening and surveillance recommendations. And I want us to, in this session, really think about the how-to. So I'm going to be providing knowledge on the updates, but I want us to more think about application of this knowledge in our practice. And so that's what I hope we gain in this session together. I will encourage active participation. So I'm not going to be calling on anyone, although that's quite fun. We'll be using polling in this session. And feel free to use a nickname or pseudonym or superhero, or whatever you want for the poll name. We won't display your name, but if that makes you feel more empowered or makes you feel more confident in providing responses, then please do so. Because this is a safe psychological environment, we want it to be a learning environment, and learning environments need for us to feel safe in them. So our answers today are confidential. We can make mistakes. We need to all give it a try. When we test our knowledge, we gain something from that. And so what goes on today really should stay in this session. And as fellows, we should all remember that as well. Next slide. So the polling is going to be through this site, and I would encourage you on your smartphone to use the polling. And if you're watching the session on your laptop or desktop, then that would be the best. So you can watch it on there and then answer the polling questions on your smartphone. So please, you type in this URL, pollev.com/academendoscopy. And I'll give everyone a moment to log into that. And I'll take this time too to say that, so Roy Satikno, who we founded a nonprofit, the Academy of Endoscopy together, really focusing on teaching endoscopy across the world. And he is helping to support this polling for this session through our nonprofit. So we'll put this in the chat too, in case anyone isn't able to get this on this slide. So if Tiffany or Neem, if you could paste that URL in the chat just for access, okay? Next slide. So let's step back again about colorectal cancer and why should we care about this so much? And the reality is that in the United States, one in 25 people will be diagnosed with colorectal cancer in their lifetime. So we have about 30 participants on this Zoom session. And so at least one of us is going to be diagnosed with colorectal cancer in our lifetime. So the prevalence is very real. It's common. That's why it's a public health initiative. And we're really fortunate in our field that we can make a difference in such a prevalent and often fatal disease of colorectal cancer. Next slide. And the good news is that rates of colorectal cancer have been decreasing. Starting about a decade and a half ago, there was initiatives for colorectal cancer screening. And you can start to see after those initiatives that when screening initiatives happened, then rates of colorectal cancer started to decrease. And this is sort of the first years we're seeing this turn. Peaked in about 2018 or so, 2008 or so, and it's been decreasing. Next slide. And so I'd like us to think about what factors do you consider when we think about colorectal cancer screening strategies? What do we think about when we recommend a colorectal cancer screening strategy to a patient, or when we're just thinking about these in general? What are some of the variables or factors to consider? And this is just a word response. It's to stimulate our dialogue. And so I want you to think about that and enter a factor. So age, family history, history of polyps, size of the polyps, literacy, okay, good. Compliance, excellent. Health of the patient. I'm seeing a lot of family history and age, really important factors for screening recommendations. Comorbidities. If access, yes. So I'm seeing themes of access and where was the other word I saw earlier? Compliance, access, compliance, literacy, age, comorbidities. All of these are definitely factors in considering what colorectal cancer strategy we recommend, and the ability for the patient to do it in the frequency in which they would do it. So next slide. And so some of the factors, and there are more than this, but this is just some to have us pause and think about them. So first, I would think, well, what's the diagnostic performance of the screening test? So they aren't the same, and we need to realize that. A FIT is not the same as a colonoscopy in terms of its diagnostic performance. A CT colonography does not have the same diagnostic performance as a stool DNA test. So these things all should be considered when we recommend screening strategies, because some patients may prioritize the diagnostic performance of the test. The other thing that may be prioritized is the frequency. So you don't just get one test at one time. Depending on the test, because of that diagnostic performance, which is calculated based on compliance with the recommended frequency, those frequencies can be anywhere from every year to every 10 years. And so we need to think about that when we're considering screening strategies. The location, which would be like access, we talked about, or ability for someone to get to the location, whether that be doing things in their home or requiring a hospitalization. The requirements of the screening strategies, if they have to do preparation work, such as a colonoscopy or a CT colonography, the comorbidities influencing sedation or ability to be sedated, taking that time off of work for some of the procedures, or having a driver needing to accompany you and that person needing to take time away from responsibilities or work. And then the other thing to think about is, if you're getting a test, well, what will you do with those test results? If there need to be follow-up procedures, if an abnormality is found, if they're not well enough for a colonoscopy, are they well enough for a colonoscopy after you have a test result that tells you they need one? So things to think about. And then the cost. So definitely many factors in considering screening strategies, and they're overlap and they can become dynamic. Next slide. So let's think about this. You have a 52-year-old average risk woman who presents to discuss colorectal cancer screening options, and she specifically asks you about the common factors that lead to colorectal cancer death. We want you to rank the following from the most common to the least common contributor to colorectal cancer risk. Okay, I think you can show the response. Oh, there's just one response, huh? How many people responded? Does it tell us? Yeah. Okay, there's 30 of you on the call, and there's no penalty for participating. And we only grow as learners if we challenge ourselves to what our knowledge is, to see what we know and what we don't know and how we can learn together. Okay, so let's show the responses then. So never get a screening test. Okay, lack of follow-up on a positive screening test. Inadequate quality of the screening test and failure to get screening test appropriate intervals. Okay, I think that we're on to something that the most impactful thing a person can do from this list to decrease their risk of colon cancer is actually getting a screening test. And it's a little bit linked the failure to have the follow-up from a positive, because but the actual getting the screening test is a significant risk reduction. And then yes, if someone has a positive screening test and failing to follow up with that could be certainly a high risk. And then these are all risk factors, by the way, but the ranking of them can be a little bit different. Next slide. And so when we look, let's talk about like colorectal cancer screening and who we should do it in. Historically, it was recommended patients between the age of 50 and 75. And what we noticed in the past decade or two, but particularly in the past decade, is increasing rates of colorectal cancer in patients ages 40 to 49. And this was across the board in stages. So next slide. When looked at a little bit more stage specific between local, regional, and distant, we noticed in the past decade, so 2011, 2015, there was a significant increase in incidence of colorectal cancer in patients 40 to 49, and that was predominantly in distant stage disease. So concerning trend that was observed and published in 2019. This led to the American Cancer Society in 2018 to provide an update. And basically what they said at that time was, we recommend to begin screening for colorectal cancer at age 45. But the problem at that time is it was a qualified recommendation and not a strong recommendation. And the ACS essentially was setting the groundwork, but the other societies, such as the GI societies, as well as the US Preventive Services Task Force, as well as CMS, had not followed suit at that time. So in the past 3 years since that was recommended, if a 45 to 49-year-old had a colonoscopy, it was basically dependent upon the insurance company if that was paid or not, because of it was only one major society recommending it. And the support of the data at that time showed that in this age group, 45 to 49, they had a general high percentage of all colorectal cancers. You can see 5% compared to the 50 to 54 being 7.6%. And years lost was significant. And so almost comparable, this 45 to 49 age group, to the 50 to 54. Next slide. And then with further data that came out in the past year or two, you can see similar data that colorectal cancer risk among people 45 to 49 is similar to the 50 to 55-year-olds, and that it was increasing by about 30% over the past 2 decades. It also showed increases across ethnicities. And so essentially, and when you looked at like patients under 50, the bulk of the incidence was happening in the 40 to 49 age group. And so based on this data, as well as others, next slide, there had been an update then in the past, in the spring, that essentially the US Preventative Services Task Force came out with recommendations saying that patients 45 to 49 recommended screening for this, that there was moderate net benefit and moderate certainty. So it went from that qualifier to something that was moderate. And this was a big deal because with this recommendation from the US Preventative Service Task Force, next slide, with this often follows CMS coverage for colorectal cancer screening. And so what you'll realize in medicine is that things are often not done unless there's an insurance coverage for them and a code for them. And so when CMS came out and said, you know, we are going to cover colorectal cancer screening in 45-year-olds from now on, then what happens is that 45-year-olds and older can get screened because there's insurance built through Medicare, and then the private insurances often follow the CMS coverage guidance. Next slide. And when we look at cost effectiveness, which is what many of the, they looked at models and they looked at cost effectiveness studies in the US multi-site, in the US Preventive Service Task Force recommendations, you can see here that the number of people screened when you look at like 45 to 75-year-olds versus the 50 to 75, this is just sort of an illustrative graphic of this. You can see that there's lots of lives saved here and cancer deaths prevented looking at that shift. Next slide. And so it does seem that screening starting at age 45 is cost effective. And that colonoscopy screening is essentially 4 colorectal cancers and 2 colorectal cancer deaths per 1,000 screened. And if you think about an average colonoscopist perform between 250 and 750 colonoscopies in a year, so you can think about the impact we can have as individual endoscopists in our patient populations by shifting the age to these 45-year-olds who have lots of life yet left and lots of years to be gained by saving death in this cohort. You can see the quality of life years adjusted, those years gained with this strategy. Next slide. So the patient who had asked about earlier about their risks for colorectal cancer, this same patient heard about a stool DNA test and a blood test for colon cancer. What do you advise her regarding her first tier colorectal cancer screening options that were recommended by the U.S. Multi-Site Task Force in a 2017 screening document? So for her colorectal cancer screening that she's considering, she talked about her risks. She felt like she was going to get that screening, which seemed to be the highest risk reduction for her. And now she's wondering what screening strategy she should undergo. And her friends told her about the stool DNA test as well as a blood test. What's considered a tier 1 colorectal cancer screening test? You can give it another moment for people to participate. Okay, you can show the responses. And so colonoscopy every 10 years, yes, that is considered a tier 1 test. Next slide. In the document that the U.S. Multi-Site Task Force published in 2017 on colorectal cancer screening, they'll be publishing an updated screening document soon. They released a statement basically supporting the 45-year-old age range start. But these tiers won't change for now. Tier 1 is considered colonoscopy every 10 years or annual fecal immunochemical tests. And tier 1 basically is considered based on cost effectiveness studies, based on access, based on these intervals. They're considered tier 1 tests. And tier 2 tests are considered, they have efficacy, some not as strong, data not as strong, and really just the reality, like flexible sigmoidoscopy probably has the most randomized controlled data out there. But in the United States, for example, we're not doing sigmoidoscopies for screening. We know that sigmoidoscopy does not reduce the cancer rates in the right colon, et cetera, so considered a tier 2. But compared to nothing, it's certainly it shows screening efficacy. And then tier 3, that blood test, that septin-9 capsule, colon capsule, those things are considered tier 3 for recommendations. Next slide. And when we think about the screening interval, we do need to think about, well, what screening test are we recommending? And when we discuss this with the patient, we need to discuss how often will you require this? And so these are based, these intervals are based on screening intervals. And that means that the patient has a normal finding. So whether it's a normal colonoscopy with no polyps or a normal FIT or a normal sigmoidoscopy, these intervals are based on that. So every year for a FIT, if it's normal, they come back next year and they get another FIT. If it's normal, they come back next year. So again, that diagnostic performance, test performance characteristics are based on the intervals that are recommended. Next slide. And so when we do talk about screening, we talk about colonoscopy for screening, it really is important to measure quality. And when we talk about FIT for screening, it's really important to measure quality, adherence to follow up for positive FITs, time to follow up if a positive FIT. So all of these things in our screening requires high quality measurements and feedback during the way. So next slide. And for colonoscopy specifically, we have a great strong predictor for colorectal cancer with a quality metric called the adenoma detection rate. This is something that is very familiar to all of us as a strong metric to reflect our quality, as this was shown to us that each 1% increase in adenoma detection rate was associated with a 3% reduction in interval colorectal cancer and 5% reduction in colorectal cancer death following colonoscopy. And I emphasize the point that there was no threshold above which increases in adenoma detection rates were without benefit. So I say this because in the next slide, you'll see that there are updated adenoma detection rate minimum targets or benchmarks of 25%. This number is very easy to achieve by most. And for example, in a VA, when we look at our national VA data, the median ADR is 43%. So this minimum target of 25% is quite achievable. And that no threshold at which there were without benefits really speaks to that. We can continue to improve ADR and have benefit from that. But ADR, like, what is it actually? And so when we calculate our ADR, it's actually the number of screening patients with at least one adenoma divided by the total number of consecutive patients who are of screening age. So it would shift soon to be 45 years old or older. At the time of this publication, it was still 50. So your numerator is the number of screening patients who you found at least one adenoma in, and your denominator is all the patients who you perform colonoscopy for screening. And that's important because you aren't going to include surveillance in that numerator or denominator. You're not going to include diagnostic exams. It's just screening. And you also wouldn't include examinations that had an incomplete, inadequate bowel preparation or such. Next slide. We have found in efforts to measure this, both within the VA and outside of the VA, that this is somewhat difficult because we do colonoscopy for many indications, and ciphering out ADR based on indication. Someone came in with screening and they may have had rectal bleeding, or they report a change in their bowel habits, or then they say something else. So it's a little bit hard as our distribution of patient indications is a little bit tricky at times and can vary based on the doctor. And so we actually did a study looking at specifically data, and then using that data and modeling it some with simulations of different scenarios and patient distributions of screening versus non-screening, and seeing if your ADR for all your colonoscopies reflected your ADR for screening. And could we make measuring ADR just easier, and then everyone can do it, and then we can sort of measure our quality reflected and improve on it if necessary. So we published this last year to show the good news is that overall ADR or global ADR or whatever you want to call it, ADR irrespective of indication, is comparable to a screening ADR. And next slide. And we simulated like many simulations. I think we had like 20 different simulations or 21. And out of all of them, there was only one simulation that made a difference in ADR reporting for screening versus non-screening. And that's basically when the bulk of your patients are for surveillance and nothing else. Next slide. And that makes sense, right? Because surveillance patients are higher risk. They had a polyp, so that's why you're surveying them. They're more likely to have a polyp again, so it may inflate your ADR. The other powerful thing about ADR is that it's highly variable when it's been measured. So this is a study out of Kaiser in Northern California with over 300 colonoscopies and over 100 gastroenterologists at 17 medical centers, but the same sort of similar member cohort of their patients. So when you look across these 136 gastroenterologists, the ADR ranged from 7.3 to 52.5%. So it's a remarkable and unacceptable range of ADR when we know what ADR differences how it can impact interval colorectal cancer incidence and death. Next slide. And so let's do this next. Let's think about let's be our endoscopist and let's be our colonoscopist, and we're performing our colonoscopy to find polyps, and we want you to click on an area in this image that may contain a lesion. So use your phone and just tap on the area on the image on your phone that may show a polyp. Okay, so we have a little bit of a distribution. We have a collection in a couple areas that we see. So we'll take this image to the next slide. And I want you now to describe what is the prominent feature that kind of prompted or motivated your tap on that area that you think there's a polyp there. What feature do you see endoscopically that draws your attention to click that area? Okay, we're seeing fold, irregular fold, loss of vascularity, a change, borders, slightly raised. Seeing the word vessels, so vascularity, vessels, fold irregularity. Okay, so the patterns I'm seeing from this is that we're looking at the folds. We're seeing an irregularity of some sort, whether that's vessels or fold or mucosa, unclear, but there was a continuity that you were seeing, and then something became irregular. So you looked at that area, and then there's a slight raised, and then you're looking at the lines, the folds, the vessels, and you're following those around until you see an interruption or change, a loss of continuity that makes you look at an area further. So next slide, do we continue on this picture? Let's see, next slide. No, go back. Okay, so in this image, that's exactly right. We're following those blood vessels, we're following the folds, and then you can see a fold deformity and a slightly raised regularity to it, and then you lose that vascularity. Suddenly you see blood vessels and then they stop. So why is that? You see a smooth fold, but then it becomes not smooth, it becomes a little bit thicker. So all of those things should draw your attention there when you're coming out, when you're looking for adenomas. Next slide. What about this image? Okay, so we're having a collection of taps sort of at the bottom of the screen. And then there's also a few in the middle center area at that backside area. Okay, so next slide. Oh, did we not ask this? Okay, describe the most prominent feature here. Okay, great. So we're seeing this mucus, and a mucus cap has been described. But similarly, there's been a fold that has become irregular. And we also are seeing let's see, the slightly raised. So that fold becomes irregular because there's slightly raised mucosa. And what may draw our attention up front is this mucus cap. So this is a sessile serrated lesion. And you can see here the endoscopic features of that are present, the mucus cap, the indistinct borders, it's slightly raised, the cloud-like surface. And you can't appreciate as much here, but it sometimes has these like very dilated dark pits. What's very prominent here as well is if you look underneath, so on the, like at the 6 o'clock position, your eyes follow these lines, right? So if you follow these lines over as we survey the colon and we're looking in that circular way, these lines are very present, but then they get interrupted. So it speaks again to us seeing like homogeneity, us seeing continuity, following and everything looking the same, but then suddenly something looking different. Why does it look different? And in this case, that mucus cap draws our attention, and then we can see the other features. Next slide. We'll do one more of these, and then we'll have talk about surveillance in the. So click on the area here that may contain a lesion. Okay, nice. So I think everyone is looking here, and let's see why. Why did you look in this area? What were the prominent features here? This is just a closer view of that same polyp that you saw from a distance. When we're in our detection mode, we're not so close up, right? We'll miss a lot if we examine the whole colon this close. So we use those clues at first, those follow the lines, follow the folds, follow the vascularity. When there's a change in it, that's when we get closer. So that happened, and now we're closer. And what does this look like? We see this irregularity again. The fold changed, right? It became irregular. The mucosal pattern changed. It's more red. That's because the vascularity changed. So we're seeing all of that here in this example. Next slide. So quickly, inspection tips for us. We need to think about finding these lesions. So having that mindset for our ADR and even our serrated lesions. And then we won't go so much today through the technique, as I'm talking mainly about screening updates, but these are just key techniques to think about, and then tools. And maybe we'll focus on that on in another lecture. Next slide. So I want us just to shift in the last remaining 20 minutes or so to talk about surveillance, because there's certainly been updates in surveillance interval recommendations by the U.S. Multi-Site Task Force on Colorectal Cancer. These were published last March or so of 2020. And this has been an update because we talked about screening colonoscopy and screening for colorectal cancer with stool tests followed by colonoscopy for positive ones. But what do we do for patients after they've had a colonoscopy? When do we bring them back to continue to protect them? When is it too little or too much? And so the reality is that surveillance is important to reduce the incidence and mortality of colorectal cancer. But not everyone has the same surveillance recommendation based on certain factors. And there have been surveillance for many reasons. Some is the genetic risk, but others is because of missed polyps or incompletely resected polyps, et cetera. So let's think about surveillance in the next slide, and think about, like we did for screening, what factors did we consider? In this particular case of surveillance, we're going to do a surveillance colonoscopy, but what do we think about for that interval in a patient to determine the surveillance interval? What do we think about? Okay, I like these. Some of the dominant themes are quality, So was the exam a high quality examination? Was the bowel preparation adequate? That's part of that high quality exam. And then do they have a family history, a personal history, and then certainly polyps is a key factor. Their number, the size, the histology, how it was resected. All of these things are great that you picked up on all these important factors for surveillance in a patient, and the age of the patient. So when do we start or stop surveillance, and is age a factor at all? Something to think about. Next slide. So with this document from the Multi-Site Task Force, you can click the next two, I think it should, okay. Basically, there was a poster that was published with it that I would encourage you to hang in your endoscopy reporting areas that allow you to help reference this and look at this for the different scenarios. So we're going to go through some of these today to talk through them. So next slide. First, I want us all to think about which of the following fits the definition of a low-risk adenoma. Three non-advanced adenomas of 10 millimeters in size, 1 to 2 non-advanced adenomas of less than 10 millimeter, 1 adenoma, 7 millimeter with tubulovillus histology, 1 adenoma of 5 millimeters with high-grade dysplasia. So let's see what we determined. So great. So fairly obvious to everyone that a low-risk adenoma is less than 10 millimeters in size if it's a tubular adenoma. So let's go to the next slide where we talk about some of these definitions. So 1 to 2 adenomas, low-risk adenoma patient. Low-risk adenoma histology is just tubular adenoma less than 10 millimeter in size. We start to talk about advanced adenomas and classifying them as that once they're larger than 10, once they have villus features or high-grade dysplasia, these are considered advanced adenomas. And we use the term advanced neoplasia often when we start to include colorectal cancer in addition. High-risk adenomas, if you can go back one slide. High-risk adenoma is more talking about the patient, and that's talking about the number. So if they had any advanced neoplasia, or if they had 3 or more adenomas of any size. So they could have 3 diminutives, 3 smalls, 3 larges, any of those sizes. Once you hit 3, you're considered in the higher risk group. And then sessile serrated adenoma, sessile serrated polyp, sessile serrated lesion. We cause ourselves confusion by using all of these different names in the different nomenclature from pathology and our endoscopy language, but using a common term, I think we can say serrated lesions and then sessile serrated lesion, that often can determine different surveillance intervals. And serrated polyp or serrated lesion does include hyperplastic polyps. It's once we add that word sessile serrated, and it is where we think that the its cancer risk is different as opposed to a hyperplastic polyp. Next slide. So here's an example. A 50-year-old patient comes in for a screening colonoscopy. She has no personal or family history of colorectal cancer. Aside from the 2 polyps that are pictured here in the sigmoid colon, the rest of her colon was normal. So based on the findings, 50-some-year-old woman, no family history, high quality exam, found these 2 polyps in the sigmoid colon. When would you recommend the patient to have her surveillance colonoscopy? Okay, 7 years, 10 years. Okay, so between 7 to 10 years seems to be the lead here, with 7 taking the lead. Let's look at our answers by thinking about this. So first of all, what did we think those 2 polyps were? And if we looked at the polyp patterns, their color, vessel, and surface pattern, they were very classic in the type 1 NICE classification to be hyperplastic. So type 1 are those hyperplastic. They were in the sigmoid colon. So basically we would say those 2 were hyperplastic polyps, diminutive in the sigmoid colon, based on that histology, based on that optical diagnosis, and given that, she would have recommended a 10-year follow-up. So for normal colonoscopies or someone who has only hyperplastic polyps, then the recommendation is actually 10 years. And they kind of, we say surveillance, but they go back into the screening mix. Next slide. And this just, let's look at this 52-year-old patient comes in for a screening colonoscopy, no personal or family history of colorectal cancer. And now we have these 2 polyps. So kind of similar age, this time man instead of woman, still 2 polyps in the sigmoid colon. When would you recommend this patient come back? So the beauty about colonoscopy too is that we have the knowledge and the tools available to us to make diagnoses in real time and let us know what type of polyp. So we can not just say polyp anymore, but we can much more with confidence say what type of polyp. Of course, there are some where we will be removing them and sending them to pathology for confirmation. But based on the images you're seeing now, with your best guess, what you would think these types of polyps are, based on that, what would you recommend as surveillance? So here, 3 years, 5 years, and 7 years. So we're getting a mix. We've got, again, a 50-year-old person, no family history, 2 diminutive polyps in the sigmoid colon. So 3, 5, and 7. So great, we'll have something to discuss here, these different answers. And so the correct answer, according to the new guideline, is 7 years. The old was 5, but now 2 adenomatous polyps that are diminutive or small, you get a 7-year follow-up. Those 2 polyps that I showed you were type 2 of the NICE classification, very classic polyps that show features in their vessel, color, and surface pattern to be an adenoma or type 2. And the other thing that one of the polyps showed is this sign called the valley sign, which is very, very specific for an adenoma. So not all adenomas have this sign, but when you see that sign, it's very specific to be an adenoma. And so in this patient, because they were average risk, they had 2 diminutive tubular adenomas, then the patient's recommended to come back in actually 7 to 10 years based on the new guidelines. Next slide. This just reminds us of that. So if you look at the table with the updated average risk adults with normal colonoscopy and adenomas, this 1 to 2 less than 10 millimeters gets a 7 to 10 year follow-up, and that was based on moderate quality evidence and was a strong recommendation. Next slide. So we have a new patient, now a 70-year-old man or patient, no family history, first surveillance colonoscopy. So this is now, this patient is in a different group because it's a surveillance. So we need to think now what we find this time and what was found before. So on the baseline colonoscopy 3 years ago, there were 3 tubular adenomas that were diminutive or small. And now during this colonoscopy, there's this 1 polyp in the transverse colon. And I'll tell you that it's less than 10 millimeters since I don't have a size gauge. So this is we'll say it's a 5 to 7 millimeter polyp in the transverse colon. And you consider the history before of those 3 tubular adenomas. He comes back for follow-up at 3 years. So now he's here and he has this polyp. So first we want to decide, is this a tubular adenoma or is this a hyperplastic polyp? Okay. I'm hoping I sized it correctly. Next slide. Okay, so 7 years, tubular adenoma. The polyp shown here is a type 2, nice. And that, again, we could have that with confidence. You can see the brown color relative to the background, those tubular structures with the brown vessels. And this is his first surveillance. The rest of the colon was normal except for this, so recommended to come back in 7 years. Next slide. So before, just so everyone knows, this is a little bit of a change, because before, any history of polyp, you'd say 5 years, right? It was kind of easier. But now we have to think about what polyps did they have before, and then if they just have one now, that may get them to 7 years. So in this scenario, you can see in this middle column, this patient had 3 to 4 tubular adenomas less than 10 on that first baseline exam. So it came back 3 years, and now has 1 tubular adenoma less than 10. So it's saying 7 to 10 years. And I'll talk about this at the end, very end, but the ranges I think can be sometimes confusing for adoption to units and providers. And so in our unit, for example, at the San Francisco VA and in my practice at UCSF, I just simplify it and we go to the lower number in the range so that people aren't confused, because 2 years is kind of a long and 3 years is like a long range. So we just simplify it in that way so it's not as variable. Next slide. So we'll just do a couple more cases. Maybe we'll end on this case since in the interest of time. So what is the recommended interval for the next surveillance colonoscopy in this patient? 57, no known family history of colon cancer, 3 diminutive adenomas, and 1 sessile serrated polyp. And in his first surveillance colonoscopy, he then had 3 tubular adenomas, with 1 of them being over 10 millimeters. No known family history, coming back for a surveillance colonoscopy, and now has 3 tubular adenomas, 3 to 15 millimeters. You can show the results. So we have, again, have a wide range. So it tells us we should refer to that document a little bit more, and that these surveillance intervals are not straightforward, that it takes us to think about what was found at this time. And just as all of you put up there, we have to consider the size, the number, the histology for these patients, if they had a family history or not. All of those things are factors. So next slide. So in this particular case, they had 4 polyps on the first and 3-year follow-up. That puts them in that higher risk group, right? And then in this case, they had an adenoma 10 millimeters or greater. So what does that automatically get them is the 3-year there, okay? So in this case, they hit 2 of them. So they had 3 or more adenomas or sessile serrated. So that would have gotten them 3 years, but they also had at least 1 polyp that was 10 millimeter or larger, 1 adenoma or serrated lesion. So some of these things can be simplified when you group them in different ways to try to think about, okay, what gives me 3 years? What gives me 7 years? What gives me 5? Next slide. Okay, we've talked about this already, but in this case, again, we're in this middle. We were 3 to 4 adenomas in the middle. They came back 3 years, and now we're in that bottom category, that adenoma 10 millimeter or larger. Okay, so let's skip through this and skip through the next. And then I just want to end on these last slides, which are also sort of part of the recommendation. So this is the recommendation. I'm just going to summarize in these last 3 slides. So average risk adult undergoes a colonoscopy. Everyone hit on this, that the surveillance is always based on the patient had a high quality colonoscopy. So if they didn't have a high quality exam, then the surveillance interval is kind of out the door, because in all the surveillance data, it's based on people who had a high quality exam to start with. We're basically saying this patient's colon was cleared, and we're starting over, and when are they at risk for future advanced lesions or cancers, and let's make sure we do their colonoscopy before that number gets too high. So this is just a breakdown after their first colonoscopy that they've ever had, after their screening colonoscopy, when should they come back? And that breaks it down here for you. Next slide. And then the major changes from the previous guidelines. So many of you maybe just are implementing surveillance for the first time, but if you had looked at the previous guidelines and are now adopting this, the major changes are the 1 to 2 adenomas went from 5 years before to now 7 to 10. And then the 3 to 4 adenomas before was 3 years and now is 3 to 5. So if you even take a real change further, the only one is this 1 to 2 adenomas went from 5 years to 7 years. And then before this, greater than 10 used to say 1 to 3 years, but now says 1. So I think that there aren't a lot of things that had changed. It just seemed like a lot. The biggest one was this 1 to 2 adenomas can be 7 to 10 years. Next slide. And then with sessile serrated lesions, the easiest thing to do with them, because it's also similar, is to group them as if they're adenomas. So they have almost the same suggestions and recommendations as the adenomas do. And so go to the next slide. So what we've done at our center is sort of made a simplified table combining serrated lesions and adenomas, so that we can sort of just go through and say, and group them more easily so they're not so many. And we also, we're not deviating from the guidelines at all. It's just that what I mentioned, we're eliminating those ranges. So in that range that said 7 to 10 years, we're saying 7. In the 3 to 5 year range, we're saying 3. So I think that can simplify and standardize group practices or provider practices for their patients. Certainly if a patient would prefer to lengthen it, then that's a discussion that you have with the patient, and that's an option. So I think this is what we've done. This is the summary of the major changes, and I had mentioned those in the slide earlier, and this is just to reiterate that. We've provided this to our primary care physicians and as part of a consult template in order to educate and try to simplify the changes, even though it's actually, it's hard for non-gastroenterologists to sort of process all of it. Next slide. I just want to thank Tiffany here at the bottom and Carmel, who help a lot with the polling development, and Roy Satikno, who has led so much in education and colon cancer screening, both detection, diagnosis, and therapeutic modalities for it. And then this is just my team on the right in the VA, who we do a national colonoscopy quality improvement program, providing colonoscopy quality dashboards and shared learning interventions to try to improve the quality of VA colon cancer prevention. Thank you.
Thank you so much, Dr. Kaltenbach. That was an amazing lecture, as always. We'll open up to any questions. I can start with, there's a couple questions in the chat box, but one is, do you foresee the ADR being lower in the younger populations who receive screening?
It's a great question. So there was that DDW this year, there was some data that showed just like incidence of adenoma or advanced adenoma. And the 45 to 50-year-olds is sort of, we're seeing similar to the 50 to 55. So I think we're just going to be expanding our group. We're going to be expanding sort of that. And so you're saying if we're screening younger people, should we in general, would we may see a shift in our ADR? It's possible, but I don't think it will shift significantly. Otherwise, what it will tell us is that our screening isn't really as necessary, right, in this patient group. But you bring up a good point that we've brought up a lot, even in the surveillance. I think someone put the word in age for surveillance. Currently, age is not one of the variables considered. And there are peaks that we see, like 50 to 55-year-olds have a lower prevalence of adenoma in general than 65 to 70-year-olds, but we don't age risk stratify in our screening or in our colonoscopy surveillance. But I don't expect to see significant shifts in ADR. Do not.
And there was another question about, with the ranges being 7 to 10 and 3 to 5, but I think you answered that. Where do you recommend, given the recommendation to be more consistent with the lower range, to be more conservative, or do you recommend just the longer range? But I think you answered that to be just.
Yeah, I did. I answered. I think it's hard to implement ranges, and I think for standardization, we with a shorter range. But if there is a patient who prefers longer for some reason, then have that discussion with them.
Another question was, I think that most of the guidelines are focused on first degree relatives, but do you take into consideration second degree relatives in terms of your surveillance recommendations, with the longest being 5 years or 10 years?
So first degree relatives are the considerations for familial colorectal cancer. These guidelines of surveillance do not include any of the syndromes or Lynch type syndromes or familial. Those would be 5 years or every 1 to 2 years, so that those things are different. But second degree relatives, outside of you trying to assess, like through Amsterdam criteria or such, if someone has Lynch syndrome, second degree relatives are not considered to lower your screening age to be age 40 or 10 years younger than the youngest age diagnosis. So those are considered for first degree relatives.
And then there was this one that came in, and there's a 50-year-old person with normal colonoscopy. 5 years later, the PCP orders a FIT test who happens to be positive. Do we do colonoscopy?
Yeah, that's always like the clinical conundrum of like when people do FIT sort of inappropriately, right? And then how do you respond? So I think the 5 year is a long time frame, and such. Even if they did it at 1 year, sometimes you're compelled to do it. And so I think the biggest message is do FIT appropriately, because when it's not, FIT has false positive rates as well. And so we're taking screening away or access away by having it. Certainly that patient 5 years later, probably most people would recommend that they have a colonoscopy. But it just speaks again to when we have multiple screening options, how it can sometimes complicate, especially when FIT's easy to do, and so is often done inappropriately.
And then there was another question. I think it's more for opinion, Dr. Kaltenbach, where if a patient has a history of a polyp that's greater than 10 millimeters, but we don't have the pathology results to kind of make clear if it's advanced adenoma or not, do you still recommend a 5-year surveillance for these patients who are recently establishing care to a new GI, or how do you approach that?
So this patient then is having that's part of their history, and they're now undergoing colonoscopy. So had a history of
it's like a
polyp,
10
millimeter or greater, and then now has a normal colonoscopy. So in that particular case, most hyperplastic polyps are less than 5 millimeters, to be honest, right? So in that case, I think you could make an assumption that it was either a serrated lesion, sessile serrated lesion, or adenoma, which puts it into that advanced group. And then you would do the 5-year follow-up on that patient, yes.
Is there any other questions while we have Dr. Kaltenbach?
Okay, well, thank you everyone for participating and providing content for us to discuss the cases further, and good luck. I definitely think the surveillance is not straightforward. The more you use it, the easier it becomes, but I would say use the resources that are visible to you when you are doing your surveillance intervals, and practice optical diagnosis because it makes it a lot easier too. If you take out less hyperplastic polyps, you have less confusion in the end, right?
Well, thank you, Dr. Kaltenbach, and thank you everyone for joining us on a late evening and for participating on the presentation. So we'll see everyone next August for our next session with Dr. Gish on August 24th. Good night, everyone.
Good night. Thank you.